Hello, let's learn about the principles of antimicrobial therapy. The principles of therapy is based on pharmacokinetics, pharmacodynamics, infection, and inflammation, and it runs around the triad of host, drug, and bug. It's important to understand the four moments of antimicrobial decision making. First is to make the diagnosis. Second is to cultures and empirical therapy. Third is to stop the therapy or to convert it from broad to narrow or from IV to oral route. Fourth is the duration of the therapy. Let's understand some of the terms. Bacteriostatic antibiotics prevents the replication of the bacteria, while bactericidal antibiotics kill the bacteria. Pharmacokinetics is the study of the time course of drug absorption, distribution, metabolism, and excretion. This is the root what body drugs to the drug. But pharmacodynamics is what drugs does to the body. Pharmacodynamics refers to the relationship between drug concentration at the site of action and the resulting effect, the time course, and the intensity of the therapeutic and adverse effects. That's the difference between pharmacodynamics. What are the indices of PKPD? It includes in vitro activity of the antimicrobial in terms of use of standardized testing methods, use of appropriate quality control organisms, use of appropriate clinical isolates. Then we have pharmacokinetic and pharmacodynamic indices, time more than MIC, concentration more to MIC ratio, and 24-hour AUC by MIC ratio. So we have concentrated different antibiotics like aminoglycosides, wherein the peak concentration plays a role in antibiotic efficacy. While we have time different antibiotics, the more the duration of the antibiotic above the MIC, the more the effect of the antibiotic. It's time different antibiotics is in better recommended. Different antibiotic, antibiotic kills the organism when it concentrates above the MIC. Greater the peak, greater the killing. Once daily dosing of gentamicin is an example of same. While time-dependent antibiotics, the more the duration of exposure to the antibiotic in terms of through frequent dosing or extended infusion, the more the activity of the antibiotic against that organism. The principal one said that establish a rational and differential diagnosis of the patient illness. All fevers are not infectious, have a syndromic approach. We can have numerous causes for infectious such as bacterial, viral, and others. For non-infectious, we have hydrogenic, inflammatory, endocrine, and other causes. Again, within the bacterial, we have bacterial septic shock, acute organ infection, and abscesses as the causes. So, have a differential diagnosis. I have proper selection of empirical antibiotics. What is empirical? Choosing the antibiotic without knowing the culture and sensitivity, or without knowing whether the bacteria affecting a patient its identification and its sensitivity to antibiotics. So have an appropriate selection of empirical antibiotics. It should be active against the pathogen. It should reach the sufficient concentration at the site of action. It should have a narrow spectrum. It should be suited for the route. It should have the least toxicity and it should have the least costs. Regarding IV to oral, what are the criteria for considering oral options? Vital organs should be good, absence of malabsorption, oral intake should be possible, good bioavailability, adequate microbial concentration. And rule out the contraindication for oral absorption such as ongoing sepsis, necrotizing fasciitis, CNS infection, initial phase of Staph aureus bacteremia, endovascular infection. So consider the bioavailability while considering for the oral options such as linezolid 100% bioavailability, nitrofuran is 80% and other such. What are the culture caveats? Do not treat the endotracheal aspirate, treat the ventilator accident pneumonia. Do not treat the catheter tip infection, treat the catheter related infections. Do not treat the bacteria with CBD, treat the symptomatic UTI. There are positive cultures without signs and symptoms also. So positive cultures is not always an infection. Especially focus on non-sterile cultures, differentiate between infection, colonization, and contamination. Ideally, antibiotics are not required, and good stewardship and infection control opportunities should be always. Do not test or do not treat asymptomatic bacteria. There are negative cultures with signs and symptoms such as think about culture negative sepsis, prior antibiotic exposure, organisms never grown cultures like Mycoplasma, Chlamydia, Trichoma, others. Do not forget about the breakthrough infections such as Stenotypes maltophilia. Alternative investigations will be carried out to support the therapy such as radio imaging, histopathology, and other parameters. Another principle states that even in a patient with a bacterial infection, treat only when the therapy will alter the patient's clinical course. In terminally ill patient, antibiotics are not helpful. No significant changes have been observed in patient clinical status. With antibiotics or without antibiotics, similar is the outcome. So prolonged antibiotics in without uh, bone or bone flapping are not a good option. Think about the risk of MDRO and social harm. Empirical target the microbes that cause diseases in differential diagnosis. Spectrum of antibiotics is very important. Choose an antibiotic that likely covers common pathogens. Avoid the coverage of broad spectrum. Spectrum of antibiotics is very important. Choose an antibiotic that likely causes common organisms. Avoid broad spectrum antibiotics as just the referral antibiotic. Administer antibiotics immediately. Consider the patient's immune status. Host factors affect the breadth of the empirical therapy by altering the likely microbial causes of infection. Broaden the empirical cover, neutropenic patients, acute pyogenic bacterial pathogens, and subsequently invasive mycosis. Patients with defects in T cells, atypical bacterial chronic infections, and as well as pneumonia. The PKPD applications critically include the hepatodynamic plus cardiac output, altered blood file balance, no organ disinfection, renal hepatic function, organ support, and others. Critical illness drastically increases the beta-lactam volume of distribution. Net increases in the institution fluid accumulation because of the endothelial injury, especially notable in hydrophilic drugs like beta-lactam antibiotics. So, volume of distribution needs to be considered in critically ill patient, as it has been referred to the table in the given slide. Beta-lactam infusions maintains blood concentration above the higher MSC than required or required bactericidal exposure time. Loading dose before prolonged infusion must be given to achieve timely initial beta-lactam concentration. It is administered over 30 minutes. Direct is the limited IV access and 4 hour stability of meropenem. Right administration, sufficient drugs should not delivered or reach the site of inpatient. It follows inappropriate administration practices. Incorrect administration, route dilation details, and final concentration are key factors for a successful therapy. Proper administration is a mandatory practice for good clinical outcomes. Using the right dose depends upon the site of infection, quality organisms, and type of formula. Renal dose adjustment should be done using the Crawford-Kogoff equation as shown in this present slide. If the patient is dead, it does not matter if you have proper dose adjusted. Slightly quoted by Mayur Ramesh. Renal impairment is acute rather than chronic in a meaningful proportion of patients admitted to infectious diseases, and the impairment resolves within 48 hours in a substantial proportion of cases. The loading dose is an initial higher dose of a drug that is given at the beginning of the course to provide a steady state concentration. It is most useful for drugs that are eliminated from the body slowly. If loading dose is given too rapidly, the drug may give excess high concentration. So administered over 30 minutes. If first dose of antimicrobial should be full dose, irrespective of the patient's any functions. Maintenance dose, and then after the loading dose is given, the other the thing is to do have a maintenance dose to ensure the steady state concentration. Prolonged infusion will associated with higher clinical improvement. Hence, it is recommended for patients with severe infection, mainly used for beta-lactam. The first 48 hours of the critical period, inadequate therapy during the first 48 hours increases the odds of mortality. Reduction in the spectrum of antibiotics, discontinuation of antibiotics with similar activity or switching to agent with narrow spectrum, switching from IV to oral. We are bad when for stopping the therapy. For UTI, more than 70% are too long. Cellular is 80% too long therapy. So they do as per the guidelines. The longer opportunities bacteria are exposed to antibiotics, the greater the pressure, selective pressure to select for antibiotic resistance. Hence, the reason to have the duration optimal. Ask for the stop date and why, and always consider why we need the antibiotic. Shorter duration equals benefits as longer duration, supported by a number of studies. If antibiotic is not discontinued or stop date is not assigned, the alert should go to continue to fire to stop the therapy. EMR automatically stop dispensing of antibiotic with prescription without stop date. So we need this. Shorter is better is a paradigm. Oral is a new IV mantra, very convenient. No IV line, no skin contact, fewer side effects, no food overload. There is a cost saving too. If the therapy is not working, consider source control and alter diagnosis before blaming resistance and broadening therapy. If the patient has not responded to antibiotics within 24 to 48 hours, before broadening the therapy, identify the source. Inappropriate source control is associated with higher mortality, regardless of the Distinguish new infection from failure. New infection are spread in a hospital setting. It will start after resolving the previous infection. It should be evaluated differently than a patient who never responds to initial therapy. It is reasonable to treat empirically with broad spectrum antibiotics to treat MDROs. So this the present size shows that about clinical applications, when to use and when not to use the different combinations of antibiotics for carbamazepine and gram-negative bacterial infection. Thanks.